Good morning, everyone. We're so happy that you're here with us today. I wanted to welcome you and thank you for joining us. I'm Kim Parker, the Chief Program Officer of Children at Risk, and I'm so excited to have you join us today for the Motherhood Summit. For those of you who are new to us, Children at Risk is a Texas nonpartisan research and advocacy nonprofit dedicated to addressing the root causes of child poverty and inequities. Our mission is to serve as a catalyst for change to improve the quality of life for children through strategic research, public policy analysis, education, collaboration, and advocacy. This event is hosted in partnership with our Texas Family Leadership Council and a collaborative of family-serving organizations across the state. You can view the agenda for today's program and get to know our featured experts using the links dropped in the chat. If you have any questions, though, please submit those for our speakers using the Q&A function. Feedback on these events are really critical. We do these most months, and we really need your feedback to ensure that we are providing high-quality content that is useful to the work that you're doing to improve the lives of families in our state. It would mean so much if you could complete the survey we send out at the end of the event to help us continue to improve as we move forward with the events this year. After the event, all registrants will receive the slide deck and any resources shared, as well as the links to watch the recording. And we would love it if you spread that broadly to ensure that we are reaching as many people as possible. I also want to give a minute to thank our partners, Everybody Texas, United Way for Greater Austin, Santa Maria Hostel, the Early Learning Alliance, the Bay Area Houston's alumni chapter of Delta Sigma Theta Sorority, Molina Healthcare, Head Start Greater Dallas, the Texas Women's Healthcare Coalition, United Way of Southern Cameron County, Methodist Healthcare Ministries, Children Defense Fund of Texas, Texas A&M University School of Nursing, and the March of Dimes. One of the questions we've been asked is, why is Children at Risk focusing on motherhood? And I think it's important to realize that there are roughly 6.7 million mothers living in Texas, which accounts for about 33% of the state's population. The health and well-being of mothers have a direct impact on the health and well-being of their children and families. And it's vital that we address the issues affecting Texas mothers in order to create a happier, healthy future for them and for their children. Today's summits will explore some of these issues as well as possible solutions. I'm pleased to welcome Dr. Elizabeth Gregory, who will also be our MC today, who will provide an introduction. Dr. Gregory, the floor is yours.
Thank you so much. It's my pleasure to be here. Welcome everyone to the second annual Motherhood Symposium in Houston, Texas in 2023, sponsored by Children at Risk. There is so much to talk about. Since last year's summit, our idea of Texas motherhood has fundamentally changed. While some may see the recent abortion ban as a form of support for motherhood in the abstract, that often does not equate to much support for mothers themselves on the ground, as our speakers will discuss. Too often, fertility politics sacrifice real families' well-being. By law, motherhood is now something that may be imposed on women and their families against their will, and we now know that pregnant people who encounter complications like ectopic pregnancies or cervical cancer or any number of other emergencies do not have access to reliable care to save their lives here. That affects the women directly involved, but it also affects everyone else in the state, including women who might get pregnant and their partners, who now have to rethink whether they want to take the risks that pregnancy now presents in Texas. Though it has less direct effect on women with postmenopausal privilege, like myself, they too are affected by what they see happening to the status of women in the state and how it affects their family members. And men too are affected by these changes, since they also are members of families. Since 87% of Americans in a Gallup poll last year opposed total abortion bans, it's definitely time to have a dialogue here about who it is exactly who thinks putting female citizens in so little control over the course of their own lives and at such risk is a good idea. Anecdotal evidence also suggests that OBGYNs and OBGYN residents are leaving the state due to the limitations on their ability to provide necessary health care that the new rules impose, which would also lead to a lowering of good care options for mothers in Texas. And employers have to wonder how these policies will affect workforce migration decisions down the line. But lack of abortion access is just one element in the lack of support for mothers here currently, as our speakers will explore. It's always important to connect the dots when talking about families. Though some policies may not seem initially to be family-related, on further looking, they clearly are. For instance, the context created by women's low wages directly affects their kids. When compared to the highest earners in the region, white men, though Asian men are the highest earning group in Texas overall, here in Houston, full-time working Hispanic women make 37 cents on the dollar, Black women make 45, Asian women make 63, and white women make 70 cents on the dollar. That is lower than the national norm in all groups. What women bring home, of course, affects their family, including their kids and their partners. Women's low wages are linked to the state's lack of investment in an equitable education system. Your neighborhood directly affects the level of education you have access to. That is a big concern of mothers and fathers both. The lack of affordable family infrastructure support is another education-related issue, including lack of childcare and after-school care. Between the ages of 0 and 18, children are in public school during work hours 37% of the time. That's because most school doesn't start until kids are 5 years old. And then they're out 3 months in the summer, and during the year, the school day ends at 3 or 3:30 while the workday ends at 5, not including commuting time to get to pickup. The other 63% of the time, it's on parents, most commonly mothers. Those who can afford it do pay for care, but many cannot. So they either work part-time or scrabble for uncertified care, risking job loss whenever a child is ill. Women's low wages are also linked to the high rates of intimate partner violence and IPV homicide in our region. Motherhood is a key reason why women stay in violent relationships, because they can't afford rent on their own on their low wages, and they don't want to risk homelessness for their kids. Homelessness or violence is a choice. Homelessness or violence, which would you prefer? It's a choice that thousands of women, particularly mothers, face in our region every day. Our recent report found that IPV homicides doubled between 2019 and 2022 in Houston, rising from 32 to 64. That is in varying parts due to the stresses of the pandemic, but the rise has continued post-lockdowns. Other factors playing roles include the increased access to guns that turned what could have been just a fight into a fatality. 89% of those homicides were shootings, and arguably the decreasing status of women in the state, as evidenced by recent policy changes. Again, connecting the dots and naming them is key. With that background in mind, we can look forward to an important discussion today, but it will necessarily engage only some of the many issues in play. Today's topics include family planning, disparities in access to care for moms, the high rates of maternal mortality in the state, especially for Black women, and inequities in postpartum health care, as well as mental health. We have had some good news from the Texas House on some fronts, so we'll look forward to hearing about that as well. And of course, it's always positive that there's plenty of room for improvement. Our panelists' bios are on the website, so I refer you to that for details. Today's speakers will be Dr. Katherine Strandberg, Policy Director of Everybody Texas, Dr. Theresa Morris, Professor of Sociology and Coordinator of WGSS at Texas A&M University, Dr. Robin Page, Director, Program for Excellence for Mothers, Children, and Families, Texas A&M University School of Nursing, Caitlin Flanders, Director of Public Affairs for the Texas Medical Association, and Elizabeth Krause, Director of Programs for the Peregrine Fund. The format will be 3 talks, and then a group Q&A, and then another 2 talks followed by Q&A. So welcome to everyone, and please join me in welcoming our first speaker, Dr. Katherine Strandberg.
Hi, everyone. I'm so happy to be here today. I am not a doctor. I did not go to medical school. I just went to policy school, but I appreciate the elevation in my education. I'm the policy director for Everybody Texas. We are the largest Title X grantee in the country. And yeah, let's pull up the presentation and I can get started. Yeah, so I want to thank Dr. Elizabeth Gregory for those beautiful opening remarks and a tone setting for the challenges that we see in Texas. I'm going to talk about what our family planning safety net looks like in the state of Texas. So if you want to pull up the next slide. Yeah, so in the big picture, Texas is the largest non-Medicaid expansion state, and we're seeing big cues from the legislature that they are very uninterested in resolving that issue. This means that there are 1.9 million women of reproductive age in the state of Texas who rely on publicly funded family planning services in order to access prenatal care, cervical cancer screenings, STI testing and treatment, and birth control. And for context, 1.9 million women, that's the entire population of Nebraska, or the entire population, like every single person in Wyoming, Vermont, and Alaska, all combined is the same number of people who in Texas need publicly funded reproductive health care. So we're talking about a huge unmet need in the state. Some of that need is addressed by our three core publicly funded programs, our safety net here in Texas. Next slide. So those three programs are the Healthy Texas Women Program, the Family Planning Program, and Title X, where I work. I do want to say that this is everything that we're talking about for people who are not pregnant. The vast majority of folks who need publicly funded care during a pregnancy have Medicaid for pregnant women or emergency Medicaid or CHIP perinatal is how they're seeking their healthcare through their pregnancies. So first, I'm going to talk about the Healthy Texas Women Program. Next slide. Thank you. So this is the largest program in the state of Texas. It served 190,000 women in 2021. And as I go through these programs and talk about how many were served in recent years, I want you to keep in mind that 1.9 million figure. So this is really a small fraction of that, right? Eligibility for this program is pretty narrow. If we think about who actually lives in Texas, you have to be between 15 and 44 years of age. And if you're 15, 16, or 17, you need your parents' consent in order to enroll in this program. You have to be a Texas resident, a US citizen, or qualified immigrant. You have to be uninsured, not pregnant. You have to be under 204% of the federal poverty line. A big challenge in eligibility to this program is that in recent years, we moved from this being totally funded just by the state of Texas and general revenue to seeking matching funds from the federal government under what's called an 1115 waiver. And as part of that waiver process, the application for enrolling in this program, which is not health insurance, but a limited benefit package, became quite lengthy. So we went from a 2-page long application that was very easy for folks to fill out in the waiting room of their clinic to an application that, depending on how many kids you have in your household, different kinds of income, can range from a 12-page application to like a 36-page long application. So folks are really struggling to fill that application out to get access to this care. And that's a challenge that myself and my colleagues at the Texas Women's Healthcare Coalition and Caitlin, who's on this call, are all really trying to figure out what the best way is to make that application easier, to offer support in the clinics, to help folks through the application in the meantime. We're just exploring a lot of options around that, but that's kind of an aside. The covered benefits of this program are contraception, pregnancy testing, pelvic exams, STI testing and treatment, breast exams, and then recently we've expanded this suite of services to include cholesterol, diabetes, high blood pressure, and postpartum depression testing and treatment. Next slide. And then there's an addition to this program that passed last legislative session. That is the Healthy Texas Women Plus program. And so this is exactly the same eligibility as the Healthy Texas Women Program. except that you have to have been pregnant in the last 12 months in order to enroll. And so it includes all of the Healthy Texas Women services that I just described, and then an expanded suite of services that are supposed to get at some of the core drivers of maternal mortality and morbidity in the state of Texas. So namely cardiovascular conditions, mental health conditions, and substance use disorders. And so you might be looking at this and saying like, well, isn't this Medicaid? Weren't we going to like expand Medicaid? How does this work in relation to that? So I know Caitlin is going to dig into this a little bit later, but broadly, this is not the full suite of services, right? This isn't complete healthcare, where we're really trying to get this session with excellent leadership from Texans Care for Children is getting to a full 12 months of Medicaid, so that folks are not relying on this patchwork of services or this like limited suite of benefits, but instead can get whole healthcare for their whole selves in the year following pregnancy. I'll also note that there aren't numbers here for folks who have been served, and that's because this program was rolled out almost exactly at the same time as the start of the public health emergency, which meant that folks who had been pregnant within the last year held on to their Medicaid for pregnant women during the pandemic and until these last couple of weeks when we've started unwinding the public health emergency. So the group of Texans who would have been eligible for services under this program were just never enrolled in it. So we actually don't have good numbers on the impact of this program, who has benefited from it, and which service providers have enrolled in it. So it's kind of complicated as we're nearing the end of the public health emergency and looking to expand Medicaid this legislative session. We don't fully understand what the future of this particular program will be. Next slide. Yeah, so the other core state-based public safety net program is the family planning program. This program importantly serves both men and women for STI testing and treatment. And it served 108,000 Texans in 2021, again, against the backdrop of the 1.9 million women of reproductive age who need social safety net care in the state of Texas. So this program has much broader eligibility and fewer barriers to entry. So you need to just be 64 or younger, a Texas resident, and under 250% of the federal poverty level. The problem with this program is that it has been historically underfunded. We have providers in the state. There are 50 providers who are enrolled in this program at 199 clinical locations. And we hear from them repeatedly that they are running out of money in this program 2/3 of the way through the year. And the way that the contracts work is that they continue to provide care in this program after the money has run out and then seek reimbursement to make their budgets whole through HHSC at the end of the fiscal year. And that is, of course, not a sustainable way to provide anything, much less medical care. So we are really thrilled that in the base budget in both the House and Senate versions of the budget this session, there's a substantial increase to this program. So we believe that we can keep this from happening in the future. There's also a priority budget writer that would allow some flexibility on the agency's end to make these budgets whole in real time, if that's what's necessary moving forward, even with this budget increase that we're seeing in the House and Senate versions. So we're really thankful to House leadership on the budget and Senate Finance Chair, Senator Huffman, for this substantial investment to make whole this historically underfunded program. And for context, in the past, the budget of this program has been like $80 million for the biennium. And if you think about that in comparison to like the Alternatives to Abortion program, which has been historically funded at $100 million, this is a really small program, but it's incredibly important. The covered benefits here are, of course, contraception, pregnancy testing, pelvic exams, some limited prenatal benefits, breast exams, and screening, but not treatment for cholesterol, diabetes, high blood pressure. Next slide, please. And then my personal favorite of our safety net programs is Title 10. So I work for Everybody Texas. We administer the largest grant in the country. And we served 158,000 Texans at 176 service sites in 2021. So Title 10 is a federal block grant program. It was signed into law in the Nixon administration. It's been around for a long time. And it is really focused on ensuring that anyone and everyone in the country can access high quality reproductive and family planning healthcare, regardless of their hometown, regardless of their income. And so eligibility for this program is super, super expansive, and we don't ask for really like pay stubs and any of these other kind of administrative barriers to prove up that you need social safety net healthcare, right? So there's no requirements broadly in Title 10 for age, residency, immigration status, ability to pay, or proof of income. And all of the services are really defined as anything that you need to help getting pregnant or keep yourself from getting pregnant, right? So that's STI testing and treatment, it's contraception, fertility testing. And then something that's really important about Title 10 in the state of Texas is that neither Healthy Texas Women nor the Family Planning Program provide emergency contraception. So anyone who has had a contraceptive failure or a sexual assault or any number of other reasons where they might need emergency contraception can go to a Title 10 clinic to get that free of charge. And then I want to briefly touch on the fact that this says that there is no requirement for age. Unfortunately, a judge in a Northern District Court here in Texas ruled in December that parental consent is actually needed for Title 10 services because that would make it in line with the Texas Family Code. That court case is currently in front of the Fifth Circuit because the Department of Justice and the Office of Population Affairs on the federal level have appealed it. This is the same judge, yes, who recently filed that decision in the Miffy case that I'm sure everyone on this call has been doing a lot of reading about. So if you want to like connect those dots there, that's like it's a big challenge that we are currently dealing with. Next slide. And then I think I'm about at time, but I did want to give a shout out to the incredible hard work of all of my colleagues on this call and the folks who aren't here today. We are really trying to push for that full year of Medicaid for new moms in the state of Texas. So we are asking everyone to call their senators. So I hope you know who your senator is here in Texas, your Texas state senator. I'm not talking about Cornyn or Cruz. And I will drop a link in the chat for how you can find your senator if you don't know that already. And call their office, tell them that you support HB 12, a full year of coverage for new moms. We're just trying to get this thing over the finish line before the end of the legislative session. And yeah, that's all I have. Thank you.
Thank you, Katherine, so much. And now we go to our next speaker, Dr. Theresa Morris, Professor of Sociology and Coordinator of WGSS at Texas A&M University.
Good afternoon. My name is Theresa Morris. I'm a professor in the Sociology department at Texas A&M University, where I also direct the Women and Gender Studies program. And I'm so delighted to be with you here today, even if by video, due to a scheduling conflict. And I would like to thank Lindsay Wilkerson for inviting me to the Motherhood Summit, which I think is just such a wonderful, wonderful topic. Healthy moms lead to healthy babies. So again, thank you for allowing me to speak. I'm going to start by talking about the social determinants of health. And I do so using the World Health Organization's definition, which is also adopted by the Centers for Disease Control in the United States. The social determinants of health, sometimes referred to as SDH, are the non-medical factors that influence health outcomes. They are the conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions of daily life. These forces and systems include economic policies and systems, development, agendas, social norms, social systems, and political systems. And we need to recognize that the social determinants of health are a big factor that affect maternal health and also today's topic, maternal health access. I approach this topic from a reproductive justice framework, which argues that the right to decide if and when to have children and the right to raise them in a safe and healthy environment is a human right. Loretta Ross, a 2022 MacArthur Fellow and one of the architects of the reproductive justice movement and framework, articulates this framework here.
When it comes to reproductive justice, if you start with the pregnancy, you're starting at the wrong place. You have to start with what's going on in the person's life before they're pregnant. My name is Loretta Ross, and I'm a reproductive justice and human rights activist. I was one of 12 Black women who helped create the term reproductive justice when we spliced together reproductive rights and social justice, because there were social justice issues prevalent in a pregnant person's life long before they even knew they were pregnant. Because if they had housing insecurity or fear of losing their jobs or fear of violence in their lives, that would determine whether they would keep an unplanned pregnancy or not. Now, in short, reproductive justice has three basic principles. Every human being has the right to not have a child and use birth control or abortion or abstinence if that works for them. And we have to fight for the right to have the children that we want to have, and that's the second tenet. And it spawned a whole movement called birth justice, which is to control the conditions under which we have children. And then the third tenet is once the baby is born, we fight for the right to raise our children in safe and healthy environments. Now, 10 years after 1994, the LGBT movement added a fourth principle about bodily autonomy, gender identity, and sexual pleasure. I'm not surprised that reproductive justice emerged out of Black women's reproductive experiences, because when we were kidnapped from Africa and brought here to breed as a wealth building strategy for capitalism, then our children were prized. But that same womb product became problematized and criminalized after slavery. I'm really invested in people seeing their entire world through the human rights framework. It doesn't matter what economic or social system you live under, because if it protects your human rights, that's the system you need to work to build. If it violates your human rights, that's the system you work to deconstruct.
And just as an overcap, the principles of the reproductive justice framework are the right to have a child, the right not to have a child, and the right to parent children in safe and healthy environments. And I share the reproductive justice framework as a way to help us understand that maternal health access is a human right.
When it comes to reproductive,
I apologize for that. I want to share with all of you a powerful tool for understanding maternal health care and maternal health care access, and that is the Maternal Vulnerability Index, or MVI. I became aware of this tool from the March of Dimes, which you all, I'm sure, are aware, leads the nation on collecting and publishing data on maternal health outcomes, including preterm birth, low birth weight, cesarean section rates, maternal health deserts. The March of Dimes, in partnership with Sergio Ventures, also examines determinants of maternal health using the Maternal Vulnerability Index, which is the first county-level national scale tool to identify where and why moms in the U.S. are vulnerable to poor pregnancy outcomes and pregnancy-related deaths. Importantly, the MVI includes not only well-known clinical risk factors, but also key social, contextual, and environmental factors that are essential influencers of health outcomes. Differences in counties are measured using numerous factors broken into 6 themes: reproductive health care, physical health, mental health and substance abuse, general health care, socioeconomic determinants, and physical environment. The MVI assigns a score of 0 to 100 to each geography, where a higher score indicates greater vulnerability to adverse maternal outcomes. The great thing, it's an open source tool, and the 6 themes reflect 43 indicators associated with maternal health outcomes. So this map is the MVI, which integrates all of the themes. And you can see that the darker the color, the higher the vulnerability index. And so you can kind of see where there's a lot of vulnerability, particularly in the South and in some parts of the Midwest and the West. Now we'll go through each of those themes. We'll start with reproductive health care, which captures indicators of access to and availability of family planning and perinatal care. 29% of counties in the Midwest and 21% of counties in the South score very high. And you can see these differences in geography on the lighter green bars. The gray bars are urban versus rural, with urban on top and rural on the bottom. And then the dark green bars at the bottom are about Medicaid expansion. And that's a state level, Medicaid expansion. Rural counties have higher scores on this measure compared to urban counties. Most striking, perhaps, is the difference in areas that have Medicaid expansion and those that do not. Next, we look at physical health, which includes indicators of the prevalence of non-communicable diseases and sexually transmitted infections. The South is particularly affected on this measure. The top 10 most vulnerable states for this theme are in the South. Further, we see that expansion of Medicaid status is strongly linked to these scores. The third measure is mental health and substance abuse, which includes indicators of mental health status, access to mental health care, and prevalence of substance abuse issues. The South and the Midwest are highly affected, with 33% of Southern counties and 14% of Midwestern counties scoring very high. Rural areas, the South and the Midwest, have particularly high concentrations of counties where pregnant women and mothers are exposed to harmful community conditions. Over a quarter, 26% of rural women of reproductive age live in counties with very high levels of vulnerability. And the vulnerability of women living in states without Medicaid expansion, again, is highlighted here. Next, when we look at general health care, which captures indicators of health system accessibility, affordability, and quality, we see compared to urban counties, rural counties are more than twice as likely to face general healthcare difficulties in accessibility, affordability, and quality. So you can see this is a real issue in rural areas, this general healthcare accessibility. This is also geographically variant, with the problems much greater in the South and in states that did not expand Medicaid. Next, we have socioeconomic determinants, which includes indicators of educational attainment, poverty, and food insecurity. This is one of the highest scoring vulnerability themes for the West, with 17% of counties in the West scoring very high. Although note the South has the highest levels of vulnerability. In this measure, urban and rural areas are more similar. We don't see a big difference in urban and rural areas. And in terms of the last theme, we look at the physical environment. This includes a lack of access to transportation, severe housing problems, violent crime, and pollution. The physical environment burdens urban mothers the most. California and the District of Columbia score very high only for this theme. And in particular, half of all counties in California score very high on this theme. Medicaid expansion status does not seem to affect this measure of vulnerability. The MVI is also a powerful tool in that one can look at individual counties. So for today, I draw a spotlight on Travis County in Texas because of it's Austin's home. And so what you see are the different themes of vulnerability, and the dark line, kind of the loop at the bottom, that indicates the state average level vulnerability on that theme. And the colored part is Travis counties. And so what you see is that Travis County mothers compared to mothers throughout Texas, that on average, Travis County, women in Travis County are less vulnerable to adverse maternal health outcomes due to county level conditions than the average woman in the state of Texas. You can see that Travis is most vulnerable in physical environment, and you can see that on the last, that teal color. Actually, the Travis County has more vulnerability. It goes beyond the state's vulnerability in that measure. And recall that the physical environment embodies environmental factors that influence maternal health outcome, including violent crime rates, housing conditions, pollution, and access to transportation. And I'd like to kind of come full circle and reiterate the reproductive justice framework: the right to have a child, the right not to have a child, the right to parent child in safe and healthy environments are considered to be human rights. We have a long way to go to ensure that women in the US have these human rights. And the reproductive lens, justice lens, gives us a goal for what women are entitled to as human beings. But I always like to end my talks on a bit of a high note, and that is, how do we make change? Change can happen. It's happened before. It can happen again. I would say a good starting point is data like what's been provided on the MVI, because until you know where the problems are, where the vulnerabilities are by geography, it's hard to design interventions. But I would say we also need to value women. We need to value the lives of women. We need to value the health of women. We need to expand health access coverage and ensure that women on Medicaid have access to healthcare for at least a year after they give birth. We need to address the social determinants of health and make sure that everyone has the same ability to seek maternal health care. We also need to collect better data to understand the causes of disparity. In order to develop and implement policies and programs that are well designed and that address equity and access to maternal health, we need to understand the factors that cause and sustain the barriers that exist. That means collecting data, doing studies, but not just quantitative data. Women's voices need to be included to understand their lives and to know what affects their care-seeking behavior. And we need to continue wonderful summits and conferences like this. So thank you again for allowing me to speak to you. And I apologize, I'm on video. Have a great day.
Thank you so much, Dr. Morris. And our next speaker is Dr. Robin Page, who is the director of the Program of Excellence for Mothers, Children, and Families at Texas A&M University School of Nursing.
Yes, good morning. And I am Robin Page, and I am faculty at Texas A&M School of Nursing, but I'm also an advanced practice registered nurse, certified nurse midwife. So I am an active clinician serving vulnerable, low-income pregnant women in a community-based prenatal clinic on a weekly basis. I also have the privilege of serving on our statewide maternal morbidity and mortality review committee, and I am our certified nurse midwife representative on that committee. So I would like to thank the Children at Risk team for inviting me to share this information today, and most importantly, to thank all of you, the audience members who are attending today to hear more about the important topic of maternal health in Texas. Next slide. So you can see the title of my talk is that maternal health in Texas is actually a crisis for children. And data from our statewide maternal morbidity and mortality review committee report, the most recent one that was just released in December 2022, states that the 118 pregnancy-associated death cases that were reviewed during that particular cohort resulted in 6,162 years of potential life loss by the women who died, and left an estimated 184 living children who will forever be impacted by the loss of their mothers. Next slide. So just a couple of the topics that I'm going to touch on today, just in our brief time together. We're going to talk a little bit about definitions of maternal mortality and what common language is, so that we can understand what we're talking about when we're looking at rates of maternal mortality. We'll take a look at Texas by the numbers. We're also going to hopefully increase your awareness of some of the resources that are available in our state. We'll take a closer look at some of the needs specific to rural areas. We know we have, Texas is very vast with many rural areas, and the needs are especially high in those areas. But we're going to end on a high note by looking at some of the best practices and recommendations for things like maternal care workforce and other innovative programs such as home visiting programs. Next slide. So this is actually taken from an infographic that was produced by the National Institute for Healthcare Management Foundation. So it's a brief description of some of the definitions that are commonly used when discussing maternal mortality in the U.S. The far right column, the maternal mortality, the sort of strictest definition would be death within the first 42 days or 6 weeks that occurs after pregnancy, after the pregnancy ends. But then we have broader terms that are commonly used. We have pregnancy-associated mortality, which considers death that occurred up to 1 year postpartum. And this is regardless of the cause of death, whether it was pregnancy related or not. If it occurred within 1 year of delivery, then it is still considered a pregnancy associated mortality. And then our middle column, pregnancy related mortality, is similar in the timing, in that it's a death that also occurred up to 1 year postpartum, but in this case, the cause was deemed to be related to the pregnancy or initiated by some physiologic effect of the pregnancy. And these definitions are ones that are used by the CDC, the Centers for Disease Control, to standardize the data that is shared across states. So we're all hearing a lot about maternal mortality and reading about pregnancy related or associated mortality. So it's important that we know exactly what we're talking about when we see this data. Next slide. So when do pregnancy-related deaths actually occur? And so referring back to our prior slide, in this case, pregnancy-related is considering up to 1 year after delivery. And so you can see that of all of those deaths that would fall into that category, about a third or 31% of them actually occurred during the pregnancy. 17% occur around the time of delivery. And I think this is what most people think of when, we hear that somebody died in childbirth. And, just thinking popular culture, movies and whatnot often perpetuate this idea that maternal deaths almost always occur at time of delivery, but in fact, only 17% occur at the time of delivery. More than half, 52%, occur up to 1 year after delivery. Next slide. So in Texas and the US, so Texas is not unique in this regard, in that the rates of maternal mortality have worsened over the past decade. You can see some data here going back to 2013, 10 years ago. And in 2017, it went up from 18 to 20, and then in 2020 went up to 23. So 90% of these deaths were deemed preventable. And this is one of the things that the Maternal Mortality and Morbidity Review Committee considers when reviewing cases. Is that's one of the questions is we always consider, was this death preventable? And there are a number of factors that we consider when looking at that. But we look at the broader picture, and this can mean, are there feasible changes to either patient, provider, facility, system, or community factors that contributed to the death? And a lot of these would encompass the social determinants of health that our prior speaker, Dr. Morris, just referred to. We know that in many of the deaths that are occurring within that 1 year period, that social determinants of health certainly are big drivers of that. And then beginning in 2020, of course, we had COVID that has a huge effect on pregnant women. And pregnant women are at increased risk for mortality as a result of COVID, especially during the earlier days. And we saw the biggest impacts on COVID-related maternal mortality in Hispanic women. Next slide. So the report that came out just this past December, many of you might be aware it was delayed, and this led to a lot of requests to the state, to the Health and Human Services Commission, who has the ultimate decision about releasing the report. And as a result, it was released, even though it did not represent a full cohort. The 2019 data had not been completely analyzed at the time, but because there was a lot of justifiable demand from the community, the report was released with a partial cohort. And so based on those findings, 44% of those deaths that occurred within the first year were deemed to be actually related to pregnancy factors. And so some of those contributing factors that resulted in these pregnancy-related deaths, you can see here, the biggest one, actually, the last bullet point, violence, and that would encompass suicide and homicide. Other contributors, we have mental disorders, substance use disorders. A lot of the data kind of lumps all of those together under mental disorders, but in this case, the MMMRC actually breaks that out. Obesity is another one, and then discrimination. And I think this is a really important one to consider when we're looking at disparities in maternal mortality. Next slide. So speaking of disparities, we know that Black women in Texas have twice the ratio compared to white women and 4 times that of Hispanic women when it comes to maternal mortality. And this graph is from the MMMRC report, the most recent one. Next slide. So this is just showing the increase over the years. This is comparing 2018, 19, 20, and 21. And you can see the upward trend, the overall in the far left, and then the breakdown by Black, non-Hispanic white, and Hispanic women. And it is increased every year in all categories, but especially for Black women. So these racial disparities are getting worse by year. Next slide. So some of the related issues. Well, we know that Texas has a lot of healthcare provider shortages, as again, referring back to Dr. Morris's presentation and maternal vulnerability index. But not only do we have healthcare provider shortage, and this particular map is showing primary care shortages by county. And you can see the dark areas are those with the worst shortages, and that encompasses almost all of our state. But we know that we also have maternal care provider shortages, which is sort of a subgroup of healthcare provider shortages, and then mental health provider shortages. Next slide. So Texas is last in access to care. This is a report from the Commonwealth Fund. And you can see when it comes to access and affordability, Texas ranks 51 out of all of the states in the US. So this is a big problem in Texas. Next slide. So the March of Dimes, as Dr. Morris referenced, talks about, they recently released their maternity care desert report. And in this case, you can see it's actually the lighter colored counties that are considered the maternity care deserts. The right column gives you the definition. What do we mean exactly by a maternity care desert? And then we also have those that are determined to be low access, moderate access, or full access, which would be the darkest shaded counties. But again, you can see many, the vast majority of the counties in Texas are in that either desert or low access criteria. Next slide. So over 22% of Texas counties have low or moderate, so not full access. 49% meet the criteria for maternity care deserts. 55% do not have a single OB provider, and that all equates to almost 300,000 women living in a county without a single obstetric provider. And this is data, again, from March of Dimes, which is a great resource. They have a Peristats database, which I love. I often refer to that when I'm giving talks. Next slide. So we know that we need expansion of care in our rural areas. Rural counties in Texas have a high percentage of women not receiving prenatal care during the first trimester. We also know that rural areas have been highly impacted by hospital closures, and in particular for OB services. OB services are often the first to get cut because they don't make as much money as surgeries. As a result, sometimes women have to travel 50, even up to 100 miles to have their baby. And this is data from the Texas Collaborative for Healthy Mothers and Babies. Next slide. So Texas has the lowest proportion of mothers who enter prenatal care during the first trimester, only 66% as opposed to 76% nationally. And then we know that Texas has lots of babies being born. We actually have the 5th highest birth rate in the US. Next slide. So just to spotlight some of the needs in Texas, you can see the vast majority of our counties are rural. And I mentioned substance use on a prior slide. So in that regard, we are one of the top states for heroin and fentanyl arrests. We know we have high rates of substance use disorder and low rates of treatment, primarily because of lack of access to treatment, especially for young pregnant Texans. So we have a high need for mental health and substance use disorder providers. We know we have many, many mental health provider shortage areas throughout our state. We're also lacking in intimate partner violence services. As Dr. Gregory mentioned during her introductory remarks, these are lacking throughout the state and in particular in rural areas. Next slide. So what are some solutions? I promised that I would bring us to sort of a more hopeful message by the end. So we need additional training for more providers. We know that lack of access to care is huge throughout our state. So certified nurse midwives who are advanced practice registered nurses, that's my training, can help fill the gap. For CNMs or certified nurse midwives, a graduate degree is required. They have hospital credentials. We also have certified professional midwives who are also recognized in Texas as midwifery providers. However, there's no formal educational in terms of degree, college degree requirement for CPMs. And so they are limited to practicing out of hospital births. However, they do fill an important need and a gap in our state. And then we also have doulas who provide non-clinical support. They provide information to help pregnant women make informed decisions about birth. So again, serving a very important role. However, they're not involved in clinical care, but can certainly help fill the gap. Next slide. So I want to also just mention the Texas Research to Policy Collaborative, which I am actually a part of, and they recently released 2 sort of infographic reports, specifically talking about some of the solutions in terms of maternal care workforce. So I just wanted to spotlight these. The one is maternal and child health. The other is doula services, and there are links to both of these documents in the reference slides at the end. Another initiative that I just want to highlight briefly is a program that we have at the Texas A&M University School of Nursing. We have a Center of Excellence in Forensic Nursing. We were recently funded to start a grant, and this was a federal grant through Office of Assistant Secretary for Health on Safe Mothers in Texas. Next slide. And actually, next slide. Yeah. This this particular program is looking at the intersection between intimate partner violence and substance use disorder occurring during pregnancy. We know that pregnant and postpartum women are at heightened risk for victimization. So we know that best practices mean that we need to educate providers on both SUD and IPV and how we can help women gain access to the resources that they need. So part of what this grant is doing is to develop and pilot educational programs to train pregnancy and postpartum providers on SUD treatment and IPV. Next slide. So I mentioned the mental health professional shortage areas that we have in our state. Again, this is worsening. In our most recent data show that 96% of our counties in Texas are designated mental health provider shortage areas. Next slide. So another innovative way that we can address this is through programs such as Nurse Family Partnership. This is just one example of a home visiting program. This is actually a national program, but it is implemented through our state Health and Human Services. And you can see in the map, the counties in yellow are the ones that have existing programs. So we have a need for more programs like Nurse Family Partnership. It's an evidence-based program where families, first-time families, are paired with a registered nurse who provides home visits beginning early during the pregnancy and follows them until the child turns 2. So this is a long-term relationship. Next slide. So to summarize some of our best practices, we need to expand Medicaid to 12 months postpartum. Again, this was alluded to, or this was mentioned in our earlier speaker's presentation. This will help women get that critical support during what we could call the 4th trimester of pregnancy. We also need to expand telehealth services that can help bridge the gap, especially in these rural areas where there are no providers. Expanding evidence-based programs such as Nurse Family Partnership, expanding our maternal health workforce through midwives and doulas. We also need to allow advanced practice registered nurses to have full practice authority. And this is something that is currently being considered during our legislative session. It has been brought up before. So we're hopeful that this may be able to get passed with this session. And finally, we need to increase public awareness of warning signs during pregnancy. So how can we do that? Next slide. There's a program that I love called Hear Her Texas. This is a program through our state. It's actually a national program, but our state health department implements it throughout Texas. And they have a website, which I have referenced here. And it has many activities that you can do on the community level, on the grassroots level, to increase awareness amongst providers, patients themselves, their family members, to hear her concerns. When women speak up, especially vulnerable women, at-risk women, African-American women who we know are at higher risk, we need to hear their concerns. Their voices need to be heard. Next slide. Just wanted to mention briefly some of the bills that are currently in Congress. House Bill 12 was mentioned earlier by our earlier speaker to increase Medicaid coverage postpartum. There are also programs to promote more mental health professionals in our area. We know we have a huge shortage, so we need to support loan reimbursement. And then the HEAL Texans Act is the Healthcare Expanded and Access Locally acronym. And that is the bill that would provide full practice authority for advanced practice registered nurses in our state. So the final 3 slides are just my references. I've provided a lot of resources for you with direct links, and thank you for your attention.
Thank you so much. That was very enlightening. And thanks to all. Is Dr. Morris also with us? Or did she have to go off? So now is the time for the Q&A for the 2 speakers who are remaining with us, Katherine Strandberg and Dr. Robin Page. And that includes questions from the audience. But I guess the first question that I have is, why is this the case that there is so consistent lack of attention to the needs of mothers on the part of policymakers that had brought us to the situation that everyone's data describes?
Oof, that's a really big question, Dr. Gregory. I think, maternal deaths, all of these like other indicators we see that negatively impact families, those are policy choices. I do think that following the last legislative session in which Texas passed both SB 8 and then a subsequent trigger ban that went into effect after the Dobbs ruling, there is some vocabulary around urgency at the Texas legislature to resolve some of these issues. I do think that House Bill 12 that I have mentioned, that Dr. Page has mentioned, is one of our best shots at that. I will say that there tends to also be some tension around how to get at these issues, right? We're seeing priority legislation that would codify and enhance funding for alternatives to abortion. And that is being discussed as a maternal health bill, even though I think I stand with other maternal health experts to say that it doesn't actually give healthcare to new moms, which is the #1 way in which we can expand healthcare. But I feel like that's kind of a rambly answer, and I'm curious to hear what Dr. Page has to say about these policy choices.
Yeah, I agree completely, Katherine, with everything that you said. I think it comes down to access and just provider shortages. We have to expand our workforce. And, you know, I mentioned a couple of the ways we can do that. We have to have more providers. And it can't always be physicians. You know, we know that, like I mentioned, midwives and doulas and even things like community health workers in rural areas can be trained to help educate and, you know, increase awareness of what are some of the warning signs, and let me help you navigate to resources. I think we do have resources in our state that exist, even though, as you pointed out, Katherine, many of them are grossly underfunded. But even so, I find that a lot of women aren't aware of resources that are available to them. So I think we have to do a better job of getting the message out there and linking people to the resources that may be available to them. So it's a multifactorial problem, but it's going to require a lot of, I think, innovative sort of out of the box approaches. I'm hopeful that this session, we will be able to see more progress. None of these bills that are out there are brand new, like, oh, nobody's ever thought of that before. We know that a lot of these policies are implemented in other states. And, you know, we can see the outcomes, that they can improve outcomes. So I think we just have to not give up. We have to keep trying.
Yeah, I'm also really heartened by your exploration of the rural health crisis. I think that's something that we are going to dig into with a lot of other partners in the interim is rural health access, particularly the closure of these labor and delivery floors, because it seems like, in terms of if you're just doing like a basic power analysis of how the legislature works, leaning into rural health access, into telemedicine, into those big issues, and tying that into maternal health is a good way for us to build strong, powerful alliances to get some of this stuff passed. So I'm really excited to work with you once the legislative session is over, because we're all too busy before then, to really dig into those issues and develop some really strong recommendations with the rest of our colleagues in this work.
Yeah, that sounds great.
Yeah, that's fascinating. I mean, there's so many parts to it. I understand, is it funding, communications, both to the recipients of potential recipients of the services and to people who are policymakers who don't really understand the policy ripple effects or even the policies themselves frequently. So yeah, this issue of underinvestment seems to be huge. And to me, it always raises this issue of the dynamic that people think they're saving money by not investing, where actually, if you made the investment, you would actually have a lot of positive growth in your economy overall. So, I mean, that's clearly an effect that people argue around the Medicaid expansion. If you brought in that $15 billion a year, that would go to businesses in the state, and you'd have fewer employer sick days, and there'd be a lot of positive repercussions around those kinds of things, and similarly with other kinds of investment. But then there also seems to be an issue of inequity across race, ethnicity, right? As people were noting, that certain people bear the effects of these negative outcomes more than others. And the question I always want to sort of pose is, it seems as though there hasn't been enough of a discussion about what actually are the effects of equity, right? So it seems that there's a kind of fear in some population that equity for you means loss to me. And instead, and there hasn't really been a discussion, that's a kind of limited pie approach, but there hasn't really been a discussion of how equity grows the pie. And that seems like another sort of communications issue for the population, especially around issues like workforce, because one of the questions was about, what are the unintended consequences of these disparities in the population. I don't know if you have time to think about that, or if you're mostly thinking about the disparities themselves and how to address them. But do you see unintended ripple effects in your work as well?
I would say definitely. I mean, I think we have to acknowledge that equity is not equality. And a lot of people have trouble, you know, I mean, I love the graphic of like, you know, equity versus equality. And if you've been underserved or, you know, had lack of opportunity your whole life, you need a higher step stool to reach the same level. You need more support. And I think that's a difficult concept for a lot of people to grasp. And I think, you know, it is about, you know, a long-term, you know, ROI, like return on your investment. You don't always see that right away. It might take a few years, but, you know, we can't just provide coverage to women for 60 days after they have a baby and then cut them off, for example. It's incredibly short-sighted. You know, I think about programs like Nurse Family Partnership that I mentioned that really get it, because they follow the families for 2 full years with that same nurse, because they recognize that, yeah, she's not done. Like we're not going to cut off our support just, you know, after the first 2 months. Like you know, it's a process, motherhood. And that program, you know, works with first-time mothers. So it's recognizing that if we can build a strong foundation for the mother and for the child, that will have lifelong effects, and that can improve things at the community level. But, you know we need healthy mothers to raise healthy children. So, you know, we just have to acknowledge that and look further out.
Katherine, do you see ripple effects of various kinds, or not so much?
Yeah, I mean, of course I do. I think Dr. Page said it really well. I think that unfortunately, there's a lot of education that needs to be done in terms of leadership, really understanding and appreciating the actual value of equity. And unfortunately, we're seeing big challenges to those core values that we here on the screen share, right? Like, this is not exactly what we're talking about here today, but the legislature is moving to erase DEI investments in higher education. And any, you know, this like ties back into these conversations around like critical race theory in classrooms and all of that, that this like core value that equity is a priority for us, that centering the most vulnerable and the most impacted in the work that we do, those kinds of things, that vocabulary in general is really under attack, unfortunately.
So you're connecting those dots across the board, that they all interact.
It's all connected.
And in terms of the changes that would make the lower maternal mortality rates, would make families thrive in greater measure. I mean, essentially, studies indicate that anti-abortion is pro-poverty, and a lot of the ripple effect of underinvestment in families and of all kinds leads families further and further into sort of a desperation mode, and that may be viewed as one way to build a workforce if you're looking to build a very cheap workforce. But if you're looking to build a skilled workforce, that's a very different model. I don't know. Do you have a sense of what the outcomes for Texas overall might be of different scenarios of sort of expanding service for families, how that might affect the future for children in Texas?
I guess for me, I'm kind of hoping that there might be a silver lining to some of this, and that, there will be a recognition that we have to invest more in maternal health and supporting our most vulnerable families. So I guess that's my hope, because I always try to, remain hopeful for the future. And even though when we look at the data, it does seem sometimes very depressing and very dire, we have to keep looking forward. And I think we just can't give up. And, we certainly can't give up on our mothers and children and families in our state. So, we have to acknowledge that, they're worth investing, because this is what builds our future. This is our future. I mean, this is our community. But I think we also have to acknowledge that there's a lot we can do within our own communities at the grassroots level, such as, making people aware. Like, for example, I think about the Hear Her Texas campaign, and that can be a very basic grassroots level thing that anybody can do, and I think they've done a beautiful job on the website of making very accessible resources that can be relatable to anyone. They have social media campaigns, they have little videos, very brief little videos of actual women who experience challenges during their pregnancy. And these are real people, and that speaks loudly when you hear, an actual woman who experienced, whether it was, some sort of discrimination or challenges during her pregnancy. When we hear from them, when their voices are heard, that's really powerful.
Yeah, so communications is a huge part of the effort in terms of getting the word out to the larger population, it sounds like.
Yes.
Well, thank you. I think it's now time to go to our next panelist, and then we can, unless there are questions in the chat that we should be addressing, or should we come back to those at the end? At the end? Okay, our next speaker is Caitlin Flanders, who is the Director of Public Affairs for the Texas Medical Association. Welcome, Caitlin.
Hello, everyone. I think I need to be unblocked from my video. Oh, there we go. Sorry, everyone. Okay, we are good. My name is Caitlin Flanders. I'm with the Texas Medical Association. I'm here to talk about the maternal and infant health. Excuse me, so sorry. I want to begin by talking about, we envision a Texas in which all children grow up to be healthy, safe, successful, and on a path to fulfill their promise, sort of focusing on maternal and child health, early childhood, mental well-being, child safety, and protection. As of right now, Texas has the highest uninsured rate for women. 1 in 4 Texas women of childbearing age are uninsured. That's about 26%. 1.4 million uninsured Texas women are between the ages of 18 and 44. And we have the highest rate in the US, and it's twice the national average. I think Katherine mentioned this in the previous panel, but and I'm sure it's been mentioned quite a few times today already, but last session, the legislature passed 6 months postpartum coverage. And right now the status is pending with the Centers for Medicare and Medicaid. We fully intend to hopefully pass House Bill 12. It's currently in the Senate. It had unanimous support coming out of the House Select Committee on Healthcare Reform. And when it got it to the House, only 9 people voted against it. It's, a very has strong bipartisan support, and we're hopeful to see that same support in the Senate. When we talk about messaging around postpartum Medicaid for moms, it's important to connect the challenge to the system barrier. So when I'm talking with staff members or members about this, it's important that we link it to why is this a problem, and how it affects people that they know are linked to. So, oh gosh, I'm sorry, my slides are not working. Highlight the links between caregivers, limited access to healthcare, and a child's success in healthy development. I actually was born, my mom was on Medicaid, I was on Medicaid when I was young. So I try to relate it back to, talk about my story and how I was a Medicaid baby. And, sometimes people just need a little bit of help, but personalizing and personifying the issue is super helpful when you're talking to policymakers about issues like this specifically. And I will say another important thing to include is we're extending Medicaid coverage because there's already that 8 weeks mandated by federal law. We're not expanding coverage. Expanding, as most of you probably know, expanding is quite a dirty word. So extending Medicaid and supporting moms, supporting babies, and supporting moms so that not only can she be there for the babies she has or is planning to have, she can continue to have more children if that's what she chooses. So using phrases like preserving fertility, supporting moms, supporting babies is super important. Like I said, this has strong bipartisan support. In his address to the legislature at the beginning of the session, the Speaker Dade Phelan revealed that healthcare would be a top priority for the Texas House, quote, saying, quote, ensuring health coverage for new moms that lasts not 60 days, not 6 months, but a full year. Let us not forget people who need more than just a job. Even with a vibrant economy, a single parent who can work, afford childcare, healthcare, transportation, and housing is indeed rare. And then Governor Greg Abbott in his budget review, he said this session, the legislature should extend that authorization from 6 months to 12 months of postpartum coverage to improve maternal health outcomes. I recommend the 88th legislature appropriate sufficient funds to extend postpartum coverage up to 12 months and to continue the Healthy Texas Women program. And again, HB 12 was passed unanimously out of the Select Committee on Healthcare Reform with full support from everyone on the committee. There were 0 witnesses opposed to the bill, and dozens of witnesses supported the bill at the hearing, including Texans Care for Children, Texas Association of Business, the Texas Medical Association, the Texas Public Policy Foundation, Texas Catholic Conference of Bishops, Texas Women's Foundation, Mental Health America of Greater Houston, the American Heart Association, Texas 2036, and many more. As the upcoming end of the continuous coverage in Medicaid has also been a helpful talking point when it comes to addressing maternal coverage. Medicaid, the pandemic health emergency coverage was renewed every 90-day increments. People who enrolled in Medicaid since March 2020 can keep their coverage, including pregnant women in Medicaid, women in Healthy Texas Women, teens aging out of Medicaid at 19. Those populations were able to keep their coverage However, the agency is going to start slowly unwinding the coverage and doing it in several phases. I'm not sure if all of you are familiar with the PHE, but certainly want to talk about it and make sure that we highlight the implications for the unwinding when we're talking to healthcare, or excuse me, when we're talking to policymakers. And that most recent renewal of the PHE ended coverage on March 31st, 2023. And I want to reiterate, it's important that kids who are still eligible for Medicaid insurance can stay enrolled and keep seeing their doctor. Kids and new moms no longer eligible on Medicaid can smoothly transition to CHIP, Healthy Texas Women, or Marketplace insurance. That is certainly the goal of the agencies, and we're working with policymakers to best ensure that. There was a congressional bill that passed in December 2022 that delinks the Medicaid continuous coverage requirement. It's kind of just reiterating what I was saying. States can take up to a full year to unwind and do the initial renewals and redeterminations. I believe the governor said that he would like to get the unwinding done in 6 to 8 months. At least 2.7 million Texans will have to be redetermined eligible. Currently, HHSC has about 400 eligibility worker vacancies, and the processing times for new applications around 90 days. House Bill 1599, the Express Lane eligibility bill that was passed through the House and is in the Senate right now. This would certainly help with that. That would allow, they would allow the agency to use previous eligibility documents to get a child enrolled in Medicaid or CHIP. Like I said, that bill has bipartisan support and it's in the Senate. So we certainly hope to see movement on that soon to help alleviate some of the burden with getting people back into getting kids back enrolled. Some ways that people can help is utilize your events and venues to raise awareness about the end of the continuous coverage, invest in local organizations that do outreach and application assistance with children and families, support health providers that serve pregnant and postpartum Texans, educate lawmakers and support state funding to improve technology and address HHSC workforce needs. And certainly encourage people to visit www.staycoveredtx.org. Some additional bills that we are covering right now are CHIP contraception. Texas is one of just 2 states in the nation that doesn't cover birth control in CHIP. Adding this would save the state money. It's not expanding access. It's just a funding mechanism change. 12 months of birth control. So right now in Texas, women are limited, or people are limited to 3 months of birth control at a time. This bill, which passed in the House and is in the Senate, it would allow the purchase of 12 months supply of birth control at a time of oral contraceptives to help prevent accidental discontinuation. There are several bills as well as a result of the recommendations of the Maternal Mortality and Morbidity Review Committee. The pink tax creates tax exemptions for feminine hygiene products. And finally, a doula bill that adds doulas to Medicaid for reimbursement. We've all seen the studies that say, when a doula is involved, there are better birth outcomes. And that concludes my presentation.
Thank you very much. And will there be, I'm sure it will be on various websites, how these fare come June, which of them actually pass and which of them don't make it. Was there any study, or has there been a chance for anyone to look at whether the extension through the PHE of access to Medicaid had any positive effects, sort of as a natural experiment? I don't know, Dr. Page or Caitlin, have you seen any discussion of that?
Yeah, certainly there's lots of discussions. I think it's going to take some time to really fully see all of the effects. I am anticipating things, a really great report. Just again, collecting all the data, studying it, analyzing it, and producing a report is just going to take some time. And we've also got to make sure we have funding to do that study as well.
Yes, funding is always important. Okay, so our next speaker is Elizabeth Krause, who is the Director of Programs at the Gregory Fund, and she will be talking about mental health. Welcome, Elizabeth.
Well, thank you so much for inviting me to participate in today's Motherhood Summit. I want to start by attempting to establish some audience credibility. So prior to joining Perigee Fund in Seattle, that is where I am zooming in from today, I was with St. David's Foundation in Austin, serving the urban, suburban, and rural communities of the Central Texas region. And while at St. David's Foundation, I built their women's and maternal health portfolio from the ground up with an emphasis on improving fourth trimester outcomes and equity. So it's actually a really lovely experience for me to be back with a group of people trying to improve the health of children and their caregivers in the state of Texas. I know it is a hard state. Not everything that I am able to do in Seattle or Washington State can be done yet in Texas, but I am hopeful. You have a lot to build from. So currently I'm with Perigee Fund. It is a 5 years young national philanthropic organization with a pretty unique niche focus. We invest in infant and early childhood mental health and maternal mental health. We focus on families affected by trauma, poverty, and racism. And in addition to prenatal to 3 mental health, we work toward policy change that returns cash and cash equivalents that reduce poverty-related stressors to prenatal to 3 families. This is such a time of vulnerability and opportunity for families, and we find that when mental health resources are bolstered, when economic stressors are removed, we have the ingredients to come together to enable families to thrive in the first years. I don't have a lot of time with you today, so I want to cover 3 main dimensions of perinatal or maternal mental health and underscore some of the solutions already underway in Texas. I use the terms maternal mental health and perinatal mental health somewhat interchangeably in this format. There are pros and cons to different terminology. There are some nuanced differences, but for today's talk, it will again be interchangeable. So the first thing I want to talk about is how perinatal mental health issues are the most common complication of pregnancy. This is not very well understood. It is often an invisible issue, even though it is such a common issue. Estimates are that up to 1 in 5 of all perinatal people experience a maternal mental health issue. The issues can come in different forms. Most commonly, the baby blues, perinatal depression or perinatal anxiety disorders, we call those PMADs, postpartum depression, birth trauma, that can lead to some mental health challenges. The issues can also come in more severe concerns. So substance use disorder, post-traumatic stress disorder, psychosis, suicidal ideation. And as we heard earlier, some of those more severe forms of maternal mental health disorder can be leading drivers to the maternal mortality crisis in the state of Texas and nationally. On really hard days, I cling tight to the fact that for the most common perinatal mood and anxiety disorders, we know how to effectively treat these issues. There are some evidence-based prevention models that we can lean on, and early identification of these issues can make a tremendous difference to moms, their children, and to communities. What the challenge is a mismatch between the solutions we already have in the toolkit and our ability to get those tools and interventions to the moms who need them, when they need them, where they need them. So Cox et al. Did a pre-pandemic study of a sample of women who had experienced postpartum depression and found that only 30% of mothers were identified, the depression was identified in a clinical setting. So again, only 30% of the postpartum depression identified in a clinical setting. Only 16% received any treatment, even minimally effective treatment. 6% received adequate treatment. So that means they received the type, intensity, and duration of treatment that has an evidence base behind it. And only 3% achieved complete remission of symptoms. So all of that is simply unacceptable. Again, when we know how to treat these issues, to have only 3% of mothers getting treated to full remission of symptoms is telling us we have a long way to go. I like to think about maternal mental health issues as biopsychosocial. We had some great prior speakers talking about social determinants of health. Certainly, there are biological markers and risk factors for maternal mental health, genetic risk factors, heredity, whether or not a mom has experienced prior mental health challenges before pregnancy and childbirth. Hormones come into play associated with pregnancy and childbirth, but there are also social factors. And so as other speakers have mentioned, when many mothers are living day-to-day life in poverty, experiencing domestic or community violence, having access issues with childcare, experiencing racism, it can be about what is happening inside the chemistry of the brain. And it also is sometimes a normal response to the way society doesn't support families with very young children enough. And so that's why we see quite a few maternal mental health issues happen during pregnancy and in that postpartum year. But the tail of maternal mental health issues can actually last 2 to 3 years, so extending into the very early years of parenting. And this is also why the social factors are why we saw big spikes during the height of the COVID-19 pandemic. This brings me to my second point. Maternal mental health is a birth equity issue. So while 1 in 5 of all moms experience a maternal mental health issue in marginalized populations, so mothers of color, teen parents, low-income mothers, rural mothers, estimates are as high as 1 in 3. The access to maternal mental health care has barriers that mirror the access barriers that previously were discussed, and why we see other health and mental health inequities persist. So, they include lack of postpartum Medicaid extension. We have a grantee, Parag Fund has a grantee looking at the different screening tools that are commonly used for perinatal mood and anxiety disorders. And examples that you might be familiar with are the Edinburgh, the PHQ-9. When we talk to mothers and advocates who are people of color, they often tell us that these screening tools don't reflect the experience that they have. There are stigmas and cultural and linguistic barriers. There is a lack of a culturally and linguistically concordant workforce. There are so many reasons why this is an inequity issue. And if we want to address the inequities, we need to broaden the set of tools that we have. So we do have some limited health system responses that are effective, but they are not enough. And so we need to push out, and people of color need to be in the lead in shaping what the equity solutions look like. My third point is that maternal mental health is a two-gen issue. I agree with children at risk that we can't have healthy children without healthy parents or caregivers. I started my career working with adults, and as I moved over into early childhood work, I was baffled that sometimes, like, I think it's unintentional or unconscious, but the approach is ostensibly treat young children as if they exist in a vacuum. And in the infant mental health field, there is a quote by Winnicott that we often share, and that is that there is no such thing as a baby, only a baby and someone. So at the end of the day, Pedagogy Fund is an early childhood funder, but so many of our efforts are focused on parents and caregivers because it is just necessary to have better child outcomes. So maternal mental health issues are associated with a number of child outcomes that can begin manifesting in infancy and early childhood, but that do persist into adolescence. So social, emotional, cognitive, language, motor, adaptive behavior development. And there are different pathways through which this happens. So, these maternal mental health issues can be, they are not always, but they are frequently a young child's first form of adversity that they experience. And so one way is through the womb environment, through physiological factors. And we know that maternal mental health issues are associated with higher rates of preterm birth, for example. There's also a super interesting and devastating study that recently came out looking at, it was a longitudinal study looking at children born after Hurricane Sandy. And I mention this because while Sandy happened in the Northeast, hurricanes affect parts of Texas, every now and then in really traumatizing ways. And so these environmental emergencies are traumatizing. They're highly stressful, highly destabilizing to people who are pregnant. Girls who were exposed to Sandy in utero had a 20-fold increase in depressive disorder. That was a 30-fold increase in depressive disorder, a 20-fold increase in generalized anxiety disorder. Boys exposed to Sandy in utero, feeling the mother's stress, had a 60-fold increase in attention deficit hyperactivity disorder, a 15-fold increase in oppositional, defiant, more combative behaviors. So one thing that I look toward as a hopeful, innovative solution in Texas is the work that the Hackett Center is doing, part of the Meadows Mental Health Policy Institute. The Hackett Center is working in Houston and along the Gulf Coast with families that were affected by the trauma of Hurricane Harvey and really trying to bolster family mental health. So, but this is just a expanded, illustrated example about how that can happen even during pregnancy. Something that Pedagogy thinks a lot about is how maternal mental health issues get into the relationship between the baby or young child and the mother. So maternal mental health issues can affect early bonding, the formation of secure attachment, attuned parenting. And this is not to blame. We do not want to blame and shame mothers. This is a health condition that they need treatment for. And we need to understand that this also affects young children. Our Pedagogy's founder, Dr. Lisa Monet, is an infant and early childhood mental health psychologist. And she's actually retired from most of her clinical practice. But she shares a powerful video that I don't have time to share today, but it shows a before and after of a mom with postpartum depression and her infant. And in the before video, she's holding the infant. The infant is fussy. She's looking around the room, like agitated, jittery, not making eye contact. She's trying to soothe the infant by, kind of rocking him, but in a again, jittery way. And then in the after video, after her postpartum depression has been treated, she's smiling. She's speaking in a warm voice, making eye contact with her baby. The baby is responding to the connection, soothed, attuned, they're co-regulated. And so it's such again, a powerful example of how these issues can get in the relationship, and it's why it's so important to treat the issues. And so, and she said, this mom, when she saw the video footage of herself, said, I never want to see my child to see my depressed face again. I'm running out of time, so I do want to just send the message that investing in addressing maternal mental health yields great returns because the benefits spread across 2 generations. Perigee recently released a report. I think there's a slide, just one slide to flash up, and we'll include it in the links and the follow-up materials. It's Maternal Mental Health, an Urgent Priority. We brought together some of the leading thinkers in the field of maternal mental health, as well as adjacent leaders. So not in maternal mental health, but who have a track record of moving issues that have high population significance, but low prioritization and resources. And the strategies in the report include health system strategies, strategies for communities, narrative change strategies, and they're divided up in terms of both inside and outside strategies. So inside meaning within existing institutions and systems, things that we can do, as well as things that we can try to do in communities as advocates to get the systems to be more responsive, and for those who just want to build a better system altogether. So again, that will be a resource. I do have some thoughts around what exists in Texas that you can build on, but I don't want to go over time and cut off discussion. So I'll end here. And if people would like to know more about those things in the Q&A and panel discussion, I can go into them. So thank you so much.
Thank you, Elizabeth. That was really enlightening as well, and gave a lot of depth to understanding the role of mental health in every aspect of life and in health overall, but also the health of the community. Since we have experienced over the past few years such a big challenge to the mental health of so many people around COVID and the lockdown and things like that, I think there's been an even bigger recognition of the importance of mental health to everyday operations in the state and in the nation. So are there questions in the chat? I'm afraid last time I did not see them in time, but the question that always comes up, we recognize that there's so much research that's been done. People do know how to fix many of these issues, as you outlined, and the dynamic is one of getting those programs funded, and the question always is, well, how do you change the conversation here so that there is more recognition of the importance of investing in the population to the success of the state? And what do people see as factors who have been inadequately involved in changing the discussion? For instance, employers. What role do they play, since a lot of the dynamic around population and fertility is around workforce, right? Like who will be working? And we know that parents, as soon as a person becomes a parent, they become another kind of worker, because that's going back to your point about babies and children being babies and mothers being one entity, that they change together, and somehow immediately you have a child, you have to be earning the funding or bringing in the funding to support that child. So that makes people much more willing to take jobs they might not otherwise take, or multiple jobs, or the many ripple effects in that way. Have you reflected, either of you, on how to change the discussion in the context of Texas, where there has been a history of underinvestment in social services, in an environment where we know that social service investment could be transformative on so many levels? Caitlin or Elizabeth?
Yeah, I think it's, we have conversations with policymakers all the time about what's going to happen if you don't fund these programs. I think during, it was either at the end of 2020, yes, at the end of 2020, leadership came to agencies and said, go ahead and make 5% cuts across the board. So that impacted everything from, children's advocacy centers, domestic violence, women's healthcare, children, all the programs that you could think of that are funded by the state. 5% cuts are detrimental. So, we, at that point, people started having those conversations of, hey, here's what's going to happen. And they ended up not making those cuts. They spared HHSC from those cuts. However, it's important to continue to have those conversations. And I think that politics comes into play here. And making sure that funding is secure isn't as easy as saying, hey, go ahead and fund this. Here's the data. Here's what's going to happen, because you have 1,000 other people with their hands out for their programs. And it's a difficult position to be in, and a difficult thing to say, hey, we're not going to fund ECI, but we're going to go ahead and fund this program over here. You can show someone the data all they want, but again, when politics is involved, it's not as black and white as we hope.
Yeah, I mean, I think it is often a matter of finding the will and the resources too, but finding the will. When we do have solutions, we just need to scale them and get them to the people who need them. And that is a harder thing in rural areas and in populations that experience the most inequity, of course. St. David's Foundation started its women's and maternal health portfolio with me leading that work in 2016, as Texas was making headlines as the place with the worst maternal mortality in the developed world. We see the tragedy in Duxbury, Massachusetts, where Clancy is her last name, killed her children. We don't have all of the facts, but it's believed that she had some form of psychosis. So that is bringing attention and resources to the issues. Sometimes we have to use these windows, even though they seem very sad and negative, to try to effect change. So that is just something that I would add. Dr. Gregory, I see a question in the chat about programs for mothers that are refugees or immigrants. I don't want to take over your moderator.
Yes, what are the programs for mothers that are refugees and immigrants? And the reason that the person is asking is to know if their assistance in native languages of the mothers, like Swahili, Dari, Pashto, Arabic, etc., are available.
Yeah, and I can't name specific programs since I'm no longer working in Texas. I've been out for a couple of years, maybe others on the panel know, but this is a really important access and equity consideration. And one of my recommendations to this group, we need to engage all who work with pregnant and parenting families where they are in communities. So one strategy, because there is just not enough mental health workforce, period, is to what they call task shift. And so that's to engage the community health workers, the promotoras, and Texas has been a leader on community health workers, doulas, home visitors, mental health peers, in like getting some of the training around how to do the psychoeducation, how to do some of the screening even for maternal mental health issues and some of the other maternal and child health issues that other speakers have talked about, and then be able to link families where there's higher clinical need to other resources that are deeper into harder to access systems. But Perigee does have a number of grantees in Washington State and other places that are working with immigrant communities. And there is a lot of need for not just like language translation, but cultural translation. So we are working with a refugee community in Washington State, working with East African immigrants and refugees. And while they've experienced a lot of trauma that affects their mental health, the concept of trauma needed some cultural bridging. So again, it's not that they didn't experience it, but there was an opportunity to do really culturally rich programming there.
Yeah. In terms of the dynamics of outreach and getting these issues heard, I mean, I assume when you say, Caitlin, that these issues are political, that means that voters can affect them by bringing them to their legislators if they feel that they are important. Is that something that communication to voters to sort of connect dots is improving? Are there advances in that realm so that that kind of clarity about what people value can be shared with legislators?
Yeah, usually when I do presentations, I always ask everyone in the room, hey, do you know who your state rep is and your state senator is? And, ask them who their elected officials are. I think having a line of communication with your elected officials is one of the most powerful tools you can have. I represent physicians, and my goal at the end of the day is to have an elected official just, hey, text a physician on the floor, hey, there's this bill that does this for medicine. What are your thoughts on it? And so I always encourage everyone to establish that kind of relationship with your elected official. Let them know what's important to you so that they're coming to you as a resource. Hey, there's this bill that does this for moms. What are your thoughts? I know we had that conversation 2 months ago. Or, hey, can I get coffee with you and pick your brain over this issue? And again, not everyone has the time or the capacity to do that, but they can call, they can email, they can write a letter, whatever communication they're comfortable with, they can certainly do that. And I'm going to tell you, they're not going to always agree with you. No one's going to agree with you 100%. But the point is, your voice is being heard, and you made sure that the elected official heard it. And it could be their intern, and it could be them directly, but establishing that line of communication is important. And I see that they put in the chat the probably my most frequented website is the Who Represents Me. Click there. You type in your address and it'll tell you exactly everything you need to know. And you can use the links to directly contact those your elected officials.
Yes, and there's a comment in the Q&A also. A critical need is federal legislation for an Afghan Adjustment Act, as the current probation ends in September, leaving Afghan families without support. So that's certainly imminent. And is that legislation that is, no, that's federal legislation. So that would be something to contact your congressional representatives around. But it's certainly a big issue here in Houston, where we have quite a few Afghan families, and frequently those are large families. So many children affected by that.
Absolutely. And I would encourage them contact your congressman, contact Senator Corden and Senator Cruz, and, let them know that you want this to continue.
Yes. So many issues, and so many of them seem almost unmanageable. That it's a balancing act of trying to move forward in a context where you have a sense that there's a big focus on not spending money when exactly what you need is that investment. So it's a complicated environment to operate in, and I guess everyone is aware of those things. But it's such a basic part of the experience of everyone. It's not a niche issue. The dynamics around the experience of families, that it's just great, all the work that everyone here is doing to raise the profiles of those issues, bring those issues, just have them resonate more and more, have people call and make those points made, because if that doesn't happen, then we continue to see these low levels of investment that really underserve everyone, not just those. I mean, I think that's the point that has to be made. It's not just the people who are denied services that lose, though certainly they are the most mistreated by the system that does that, but everyone loses as a community when we as a community do not invest in one another and don't invest in helping everybody thrive over the long term. And that's, I think, a part of the message that has to be emphasized, and with examples of how having more perspectives create new markets, create new skills levels for people to do jobs. There's so many opportunities that greater investment can bring to the state. And it all starts with young children. So they're the point of deepest investment.
Absolutely. And just one final thing, I know that it can get discouraging to constantly see, no, we're not going to fund this. We're not going to create this program. We're not going to do this, and we're not going to do that. And it's so important that everyone in this space knows how important their advocacy work is and how life-changing it is. And it may not seem like right now one little inch is doing that much difference, but keep going, change will happen. It just, like someone said earlier, there has to be a will, and I know there's so much will, and eventually we'll get there.
Thank you for those inspiring, continuing words. Keep people the energy to keep going. Thank you all for being here. And Kim, over to you.
Thank you so much. Thank you everyone for your participation today. We're so grateful that you've joined us. I also want to give a special thanks to Dr. Gregory for emceeing the event, Katherine Strandberg, Dr. Theresa Morris, Dr. Robin Page, Caitlin Flanders, and Elizabeth Krause for providing your time and expertise today. This is such a robust topic, and one that's actually very near and dear to my heart. And we're so grateful that you could kind of share your broad experience. We have so much to do in Texas and nationally on this issue, and we're so grateful for your time and your commitment. We do have a number of resources in the chat, so please go ahead and click on those and get those links. There's some phenomenal resources. But I also wanted to mention that if you wanted to help mothers in Texas, we have some action items for you. So as you've heard today, House Bill 12, we are making a lot of progress in the extension of postpartum Medicaid coverage. And so please call your state senators as we move forward with that process. The March of Dimes has also made it easy to contact your senators by simply texting postpartum to 52886 and following that link to an email to send to your state senators asking them to vote for House Bill 12. You also can sign up for Children at Risk advocacy alerts to stay updated on progress of important bills in the legislature related to this topic, as well as a variety of others. And we also have the Texas Women's Healthcare Coalition Legislative Toolkit, which is phenomenal to support women's health if you need additional resources. As I mentioned at the top of this event, feedback is really critical to us being able to continue to improve our events, but also provide the information in the content areas that you're most passionate about and that you feel will have a direct impact on us being able to improve the lives of families and children here in Texas. So please, please fill out the survey in the chat box to help us out. It'll help us inform the rest of our events for this year, but also we do these every year, and we always want to hear what topics are of most high priority for you. If you have speaker recommendations, if you have content you would like included, we really would love your feedback. Also, we still have a couple of events coming up pretty quickly. We'll have our Early Childhood Education Summit on May 11th and the Future of Children Summit, really trying to imagine what a future could look like, on June 8th. We so appreciate your participation today. We're so grateful for everything that you do in your daily work and your commitment to this issue. Thank you again to all of our speakers and our participants, and we hope to see you again at our next event. You all have a wonderful day. Thank you for joining us.